Great. Thanks very much for inviting me to speak to this very interesting society entity that I hadn't previously heard of, and of course is highly related to issues of sustainability. I'm going to talk about epidemiology and public health, as Rohini has said, and I'm based in Cambridge and have been for my whole career, and basically dedicated a lot of that time to running population studies of people aged 65 and over in general. But I wanted to show Cambridge is a very beautiful place, but it also has inequalities. And so I just wanted to highlight that I will be speaking about inequalities throughout, or sort of on and off through the talk. And the picture that you see in the bottom left is of rough sleepers, homelessness, or homeless people in Cambridge City. And we have quite marked inequalities within Cambridge City, as well as being, seen as a pretty affluent area of the country. So the issues of inequality touch us all in a really important way. Now, I wanted to just give you a definition of public health. It's the science and art of promoting and protecting the health and well-being of whole populations, preventing ill health and prolonging life through the organised efforts of society. And you'd be forgiven for thinking that medicine was all about, the next disease that you'll be diagnosed with. That's just a nice little cartoon there about the screening, that the emphasis on screening and early detection is very dominant in current discourse at the moment. But of course, it does have a major impact on us as individuals if we are screened for multiple conditions. So I'm obliged to inform you, you have the right to remain anxious. Anything you say will be used to further test you. If you do not already have a diagnosis, one will be provided for you. I just like that. And of course, we have polypharmacy, and we have multiple methods of imaging and invasive techniques of looking at inside our bodies and detecting cancer cells, etc., etc. And part of the job of public health is to try to understand all of this, and particularly to kind of integrate the new with the old, as it were, and not to lose sight of things that we have known for a long time. So epidemiology is the study of health and ill health and their determinants in communities and populations. And the most important thing probably that you could remember from this talk is that it's really important when you're evaluating research to think about what the denominator is. So to whom does anything that you read relate? So if it's research that's being presented in the media, or if it's research that you're reading in a paper, or if somebody's talking about it and saying, oh, well, this is that, that you say, well, how was that evidence generated? On whom was it generated? To whom is it relevant? And to which populations is it relevant? So you have to have a known denominator, and you have to have a defined numerator. And the numerator, of course, is the thing that you put on top. That's the top and the bottom of an equation. And the numerator, you have to know what the thing is. So you have to have a definition. And epidemiology is a lot about trying to understand what disease and ill health and health and well-being are. And conditions are often not as straightforward as they seem, and I'll give you a kind of indication of how that's played out in my own understanding across decades of research. So this is taken from the Chief Medical Report, Chief Medical Officer of England, who is in sort of charge of all health aspects in England. This is Professor Chris Whitty, and he's just recently published an annual report, which he does every year, and it's very, very interesting. He's focused on coastal health, and he's looked at inequalities and so on. This year does have a heavy focus on inequalities, but I'm putting this up because we're talking about aging today, and this just gives an indication of how much we are going to age into the oldest age groups over the next decades. So at the moment, these are the percentages of people in the population, so population estimates, and it gives you the population percentage aged over 85. And so you can see here by 2043, we're expecting a really rapid expansion in the very old. So in order to understand the very old, you really need to research the very old. So I've spent my career doing these cohort studies. And cohort studies are, you basically define a group, and they can be volunteers or they can be population representative. Then you follow them up over time. Effectively, that's what a cohort is. You follow people over time and you hope to retain them as best you can, but people obviously drop out and die, particularly in the older age groups. But so that's my kind of specialism. So I started off in East Cambridgeshire in the 40 years ago. And there were so my study was out in the fens. These are the fens. I think you can probably see my cursor. I'm not absolutely sure if you can, but here's the fens, very flat and should be underwater, but are drained like the Netherlands. This is Cambridge City, which is the Cambridge City over 75 cohort, also started at the same time. And then there was a later study which started a few years after that, after certainly I'd cut my teeth doing population studies. And the later study is called the Cognitive Function and Aging Studies, and it has these 6 sites. And in a later iteration, it added another site down here in Newport. I was heavily influenced in my master's by a teacher called Geoffrey Rose, who was one of the instrumental scientists and epidemiologists who trained enormous numbers of epidemiologists who are now senior professors in the UK and internationally. And he is well known for thinking about whole populations and risk in populations. I'll come back to that towards the end of the talk. One of the things he taught us was that if you scratch the surface of any condition, as I've hinted, it isn't quite as simple as as it seems. So in the East Cambridgeshire study, I aimed to basically look at all the variables, all of the evidence that one needs to garner in order to make a diagnosis of dementia. So I looked at all of those variables in a whole population of women aged 70 to 79. So that's hours of interviewing relatives, doing physical exams, taking bloods, and doing cognitive tests, which are tests of mental function, memory and attention and that kind of thing. And what I wanted to look at was whether the variables underlying what sounds like a binary diagnosis of dementia, you have it or you don't, whether they were continuously distributed. And that was Geoffrey Rose's influence on all of those who passed through his hands in teaching, to try to understand the condition that you're wanting to investigate deeply before you go on to sort of look at risk and so on. So dementia is diagnosed through, it's a syndrome, and it's diagnosed through cognitive testing and understanding somebody's context and health. So it's not just their cognitive function, but it's also cognitive function impairment acquired sufficient to interfere with day-to-day activities. So you can understand that it's actually quite a complex syndrome to diagnose. So it's not you've got it or you haven't. It's distributed, or the things that make up the diagnosis are distributed very differently in different populations. And you need to understand those populations and cultural settings and gender, etc., to really understand whether somebody is living with a syndrome of dementia. So this slide shows you the cognitive scores, and Mini-Mental State has become much more known since I started using it in 1980s. And so it was generated in the States. It's a short cognitive test which covers a range of types of cognitive function. And this was a cross-sectional, so just all at one time, distribution of scores in the population in East Cambridgeshire that I interviewed and examined. And you can see the ages here, and this is a really old, taken off old slides actually. But you can see these are continuously distributed. So you've got a continuum slightly lower in the older age group and slightly higher in the younger age group. And of course, that could be due to different age groups having different education. So from cross-sectional data, you can just simply describe. You can't really understand any fundamental things, but it can be very useful to know. So epidemiology, cross-sectional findings can be very useful for service planning and that kind of thing. So that showed that the variables which are used to make a diagnosis, because you have to do cognitive function testing, are continuously distributed in the population. And other studies, of course, have shown that sort of finding. However, using all of the things that I mentioned, so physical exam, neurological exam, bloods, interviewing people and asking lots and lots about their lives and medications, daily activities, all of those things. We do make a diagnosis of dementia in these studies. And in the late 80s, a European Union grant was successfully argued for by Bert Hoffman, who's now at Harvard, bringing together everybody who'd done that kind of study in Europe. And that included not just the East Cambridgeshire study that I've described, but also the Cambridge City over 75 cohort, which was being run at that time by somebody else. But I took it over with colleagues at a later date. Anyway, this is what you see for the studies of dementia in populations. They were all good studies done in population samples, representative communities with high response rates, like 90% in those days for this kind of work. Ours were recruited through general practices in geographical areas. And these studies were put together and their approaches to the diagnosis of dementia were all pretty similar. Proper diagnostic criteria were just beginning to be developed at that time, and these studies had all used good diagnostic criteria, or the best that there were at the time, I would say. So what that did was provide robust estimates of the prevalence of dementia, that is the proportion of the population that meets dementia criteria for that study at that time. And so what you can see here is the percentage, effectively, of people in different age groups, and then the different lines represent the different countries. And of course, they are specific geographical localities. These are not national studies. These are specific, because it's very intensive to do that kind of work, as you can hear. And you can see this extraordinary rise with age. So it's very, very age associated dementia syndrome, and as you get towards the older age groups, it comes up into very high proportions. So if we live long enough, we have a very high likelihood of developing a dementia syndrome before we die, which is one of the reasons why dementia has become a common cause of death on death certificates. It's also because doctors have been encouraged to put dementia, if it's present, on death certificates, whereas before it was usually not put on. This is the same data, or these are the same data here, but on a logarithmic scale. And you see the straight line. So this data is effectively a straight line on a logarithmic scale, which just, again, emphasizes how age-associated, if not age-dependent, dementia syndrome usually is in the usual representative older populations. So we didn't stop there. We went on in the Cambridge City over 75 cohort, which was a very high proportion of the people in Cambridge City aged over 75 and over. And I and colleagues took that study over after its prevalence phase, and we did an incidence study and published on incidence. So there are the same kind of European estimates for incidence. But what we wanted to look at as well was the change in cognition in the whole population. Because at the time people thought that you have this smaller group who kind of separate off, who develop dementia, and I wanted to see whether it was more general phenomenon. And what we found was what you can see in this slide, which is the change over 2 years in the Cambridge City over 75 cohort. Participants, people aged 75 and over a 2-year period, their MMSE declined by, on average, around 1 point. And the people down in the lowest age group, the greatest decline, clearly, those are the people who are slipping into a dementia syndrome and very obviously meet the criteria mostly, unless they have some physical cause of that decline in cognition, which can be reversed. That's actually really rare. So we showed this continuum in the population. So scratch the surface and you see a continuum. We also wanted to look at what the dropout in such studies. These cohort studies have dropout, as I mentioned, in terms of death and refusal, and the impact of that. And so I worked with the biostatisticians in the MRC biostatistics unit. And if you look at people who persist in our kinds of studies, they actually are survivors and persisters, and they tend to have started off higher in their cognitive functions. So these are people separated out into what year they were born in, and you can see it looks as though there's no change, and that's why people were thinking that the people who developed dementia were sort of different. But actually, if you look at the people who had dropped out, and what their decline was before they dropped out, you can estimate what the adjustment might be, or you can put into the analysis what the whole population might have looked like had everybody been able to take part, even if they were relatively close to death. And what you see here is that the mini mental state of the average goes down dramatically for these cohorts. And of course, education affects cognition, so you'd expect later cohorts not to be quite so dramatic or go down quite so far in this midlife, mid later life area. But this was quite dramatic for those people aged 75 and over in the late 80s. So we're talking about whole populations, not individuals. We're talking about whole populations here. We also wanted to look at what are the underlying factors related to dementia presence, taking away the filters that operate when you look at people who go through services, so from primary care to secondary care to specialist care. So in our studies, because it's totally population representative, we were able to ask people about brain donation after they died, and we were able to make our own diagnosis, so a study diagnosis of dementia, and look at cognitive function across the life course that they had remaining to them after they took part in our studies very nobly. And we were able to look at the brains and the classical Alzheimer type changes in the brain after death. And what you can see in this slide is the dark bars and the light bars. The light bars are people who died without dementia syndrome, and we had a big process of trying to work that out. And the dark bars are the people who died with dementia. And these are classical Alzheimer type pathologies in the brain. So plaques and tangles you may have heard of. And these are vessel changes, so sort of clogging up of the vessels with a protein called beta amyloid, which is also implicated in particularly in plaques, and then vascular changes like stroke and so on, which we knew played a role in dementia, and because stroke is a known risk factor for dementia. What you can see here actually is that the Alzheimer type changes at death don't particularly tell you whether somebody died with dementia or not. Of course, that's really important because it means that a lot of people die with pathology, but they haven't developed dementia during their lifetimes. And this is very important. These are all people who are in their 80s, really quite old people. So there's something about the brain, the older brain, that can be resilient to these pathologies, which is very important. And I'll come back to that. Or you can come back to other questions if I don't have time to talk about it. So now on to the last study that I mentioned, the cognitive function and aging studies in different sites in the UK. And that study was also looking at prevalence and incidence of dementia for the nation, and was used in planning for planning long-term care and all sorts. It's used in all the estimates that you hear day to day about the number of people who are thought to be living with dementia now and projections into the future. So it's been quite influential in sort of policy and practice, even at sort of GP levels, so all that case identification, if there are any GPs in the audience. Not that that's the way that we hoped that the data would be used. But we also looked at risk, because when you're doing longitudinal studies, we tried to follow people up across time. We looked at risk, and we've contributed to the Lancet Commission, which is a huge exercise led from UCL by Jill Livingston, and that puts together all the world's evidence to try to say, well, what are the robust modifiable risks for dementia, such as the risk factors for stroke. And here you can see it's basically a rough estimate trying to work out what proportion of dementia might be prevented if you were able to eradicate a particular risk factor. So what you can see here is there's early life, early education, hearing loss, and here, well, they put these in midlife, but actually these operate across the life course. Hearing loss, cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, excessive alcohol, social isolation, air pollution, and visual loss. This is not the full armamentarium of risk that's been identified, but it's risk that appears to have sufficient evidence behind it, and also some evidence of modifiability. But of course, that's a very challenging evidence base to to review, but also to assess whether the evidence suggests that it's truly modifiable. So this has fueled various policy approaches. Public Health England introduced looking at the risk profiles for dementia into the health checks. And from a public health and epidemiology basis, I would say, it would have been very important to do a trial of health checks, but given that the policy was introduced without that evidence base, one wants to make it kind of put as much evidence into it in different ways as you can. So that was one outcome of that kind of work. So this Lancet Commission is updated every few years and adds in new risk factors for which evidence becomes accrued. And 45% is potentially modifiable, but I think I've shown you also that the prevalence of dementia becomes much more common in the oldest old. So it's more a shifting of the diagram rather than being able to prevent dementia altogether, so that we push it later into life. And for the reasons that those risk factors have been identified so clearly across the decades, the cognitive function and aging studies were started off in 1991 or 89 actually, but 1991 in sort of full swing in all those centres. But things were changing. Mortality from heart disease was changing. Mortality from stroke was changing. We'd had a lot of exposure to greater education. And if you look at that lot of risk factors, inequalities, clearly, those risk factors cluster around inequalities. And inequalities change across time as well, although they are very persistent. So we made the argument that we should look at new generations of people aged 65 and over, because the cognitive function and aging study was in 65 plus. And we were successful in raising money from the Medical Research Council to repeat the study in 3 sites. That's in Cambridgeshire, Nottingham, and Newcastle. And we tried to keep the methodology as close to the original as it had been, but 20 years, effectively 20 years later, so around 1990 to around 2010. And we repeated the methods that we had used in the cognitive function and aging studies, which were slightly different from the ones that I described for the East Cambridgeshire study, but not a million miles away from it. And what we found, we had an algorithmic diagnosis, which meant that we weren't influenced by changes in diagnostic practice across time, which is really important because you can change the diabetes criteria and then, like the WHO has done, or hypertension criteria, and overnight you'll have millions more people who meet the criteria and are said to have hypertension or diabetes. So it's really important to keep the diagnostic approach steady across the decades. So this this exercise in a cross-generational comparison showed us that dementia had in fact decreased. So the prevalence of dementia, the proportion of the population who met our diagnostic criteria in the 2010 generation of 65 plus was more than 20% lower than it was in 1990, and that equates to something like an estimation of more than 230,000 less people estimated to be living with dementia using those criteria. Of course, that's at odds with the routine data statistics, because routine data are influenced by changes in diagnostic approaches, awareness, dementia awareness, and much more recording in the routine records themselves. So this is a true population comparison across time. So it tells you what's happening in the population as opposed to all the other influences that change how things might be seen. If you look at a kind of different type of evidence. So really compelling evidence of change across, because that was what the study was set up for, to look at change across generations. And we weren't alone. So this is incidence of dementia. So this is change across time, and this includes our incidence data. So incidence is the proportion in the at-risk population over a particular time period. And this slide shows you French and American and Swedish studies and the UK. And it shows you the change across generations. There are relatively few studies like this that can examine across generations. But if the prevalence, if the incidence of dementia had been stable across time, the line, you would have seen these blue squares down this line. But they're all lower than 1, which shows that, and bringing all those data together shows that across time, the incidence of dementia has declined quite dramatically across the decades. So these were studies that were done across several decades and brought together in a single analysis, again by Bert Hoffman, but from Harvard this time rather than Rotterdam. So, and the change is mostly seen in men rather than in women. In CFAS, though, in the UK study, we have found that women experienced major better well-being, if you like, or healthy life expectancy without cognitive impairment. So that was a very strong positive for women as well as men, even though the dementia syndrome estimates seem to be changed only in men. The changes in the UK were predominantly seen in the more affluent sectors of society, and in our disadvantaged areas, we didn't see the same drop in dementia. So inequalities really matter, and this is just an example, really, from the sort of what's risk factors look like in the population. And here we have deprivation, index of multiple deprivation here for different types of stroke, which are double your risk of dementia in future if you survive your stroke. And you can see that there's a huge inequalities effect in that. I and public health colleagues have came up with this sort of neurological health life course thinking about the social and commercial determinants of neurological health, because it seems that the neurological sort of we as organisms, if we can be as healthy as we can and optimal as we can across our life courses, all of those risk factors are dampened down, and many of them are associated with social and commercial determinants of health that operate across communities as well as individuals. So here we have the genes and the risk accumulation in early life, and sort of these are the ones which you've seen in the Lancet Commission, and then the pathology development, and then the neurological disease outcomes. And we tend to focus, as I've mentioned right at the beginning, on this stage here rather than thinking upstream here. And of course, nutrition feeds in all the way across our life course, including when we're in utero and our parental health. So these things are hugely important, which are across the top here in terms of how they influence whole community and population health. And they're all linked to sustainability as well. Okay, so I'm going to shift gear now, and I'm going to move on to some of these interventions that have come up as individualized interventions because of that risk data. And I've been involved in some trials as well, but I'm going to just take you through a couple of systematic reviews and one trial fairly rapidly. And of course, you can see the slides afterwards, or you read the papers themselves. But the first one that I wanted to skate through is a systematic review of multi-domain interventions. So you saw all those risk factors. So people thought, and in Finland in particular, one pioneering study thought, we know all these this constellation of risk factors, why can't we put together a whole range of interventions, such as those for social isolation, for physical activity, and I know you're particularly interested in the nutrition, so nutritional advice, and then try to influence individuals through an intervention to change those things. And so there have been all sorts of types of trials, and some of them are face-to-face and some of them are online. I can talk about the online ones afterwards in the Q&A if we have time. But there's been some good systematic reviews recently, and they followed all the kind of rigorous processes of systematic reviews. And this one in particular identified 15 studies of multi-domain interventions for dementia prevention, with about 13,000 altogether in those 15 studies, a wide age range. And in 12 of them, women tend to seem to take part in them more than men in these interventions. And the sample sizes range hugely in these trials, and they're across a whole range of different countries and cultures. So very interesting range of studies. And they, as I say, they included 40 people aged kind of wide age range, and tended to include people who had sedentary lifestyle with no or low moderate exercise, poor diet, increased risk of vascular risk, and different types of genetic risk might be included. And people with MCI and ADI or mild cognitive impairment, that's a mild cognitive impairment, not dementia syndrome. And there are all sorts of exclusion criteria in these studies as well. So in the systematic review, they found that there were very heterogeneous results. 3 studies showed no improvement, 10 showed improvement, and those included high fruit and veg, whole grain, fish twice a week, and low fat milk, sort of avoidance of red meat, the sort of things that you might expect, Mediterranean diets and so on. And one showed modest short-term improvement. They tend to be relatively short-term, these studies. So that was one systematic review, seemed to be kind of showing quite a bit of evidence in favour of multi-domain interventions. This one was published last year, and again, this one identified 16 trials. There'll be overlap in which ones were represented, and with 11,000 participants, 51 to 2,000 in sample size, mean age a bit older actually than the previous systematic review, a lot of proportion of women. Risk of bias, interestingly, was considered low by the readers, which is good, and moderate to certainty evidence of that physical exercise had modest to no effect on cognitive scores, but that multi-domain intervention, so that mixture of things that I mentioned, were significant, with the 95% close to 0. So there's still a wide range of estimates, so it's within possibility that it doesn't have an effect. And the physical exercise interventions didn't also alter outcomes of mild cognitive impairment or dementia, but there were very few studies. And the next slide is it's actually the results of the meta-analysis, which is the combined analysis, all these different trials that these reviewers have put together. And again, there's no difference in the control or the intervention if it's on 0. And what you can see here is that for some of these things, it favours intervention here. This is the physical activity. For this, this is physical activity, and this is the multi-domain activity, and the outcome here is cognition, not mild cognitive impairment or dementia. And here you have the dementia and the mild cognitive impairment, and you can see these are not significantly different, but they're a very small number of studies. So what about these studies? Should we really believe them? Well, they're a relatively small number of studies, and there's a huge variability in the populations that they study, their designs, their protocols, adherence to the intervention and outcomes. So that's where the literature sits. And then just recently, the Pointer study, the US Pointer study, was published. So there's a lot of studies going on in parallel. because there is such interest, because of all that risk factor data that I've presented. And this was published very recently. And this also does this multi-domain intervention looking at diet, particularly Mediterranean type diet. And people are randomized into really intense, I mean, it's 38 facilitated sessions, I think, for the people in the intervention group. You sure know which group you're in, so there is no blinding is pretty difficult. They're supposed to be blinded outcome measures. So the people who interview the intervention or who study the intervention and the control groups are supposed to be blinded to which group they're in, but it's very difficult to maintain that blinding, in fact. The age group was relatively young, 68, people with sedentary lifestyle, and 5 clinical sites. And they looked at cognitive function using a mixture of types of cognitive function over 2 years. So it was longer than one of the other systematic reviews, which needed studies to be at least following people for just a year. So these were the differences here that you can see here. And actually, I don't know whether you would agree, but these are relatively small differences. However, they are significant, and this is what it looks like on the graph here. But you can also see my point about it. There is a certain amount of dropout, which can be informative, as I showed you in the mini mental state follow-up of our own population studies. So these are quite small. These are quite small differences here. So what that really means is not. It certainly adds to the literature, but whether that's a major significant finding with that intensity of intervention is to be debated, and certainly to think about trying to put these types of interventions at scale in lower and middle income countries, or even in high income countries that are strapped, such as the UK, is another matter. So there were differences, of course, in different groups and whether people were favoured. But what's quite interesting is that the people who were in the lower cognition group, who were recruited here, less than median, that's the middle of the distribution, there was quite a significant increase or difference between the intervention group and the control group. And that's also been seen in some of our own studies, which are more internet and mobile phone based for this kind of thing. And the younger age groups here, under 70, see a bit more of a difference, and those who have cardiovascular disease. So it may be that a much more targeted approach for these kinds of very intensive and very expensive interventions would be necessary. However, I wanted to point out a further aspect of this study, which is really concerning, in that if you look at the number of people who were actually approached and then the number of people who took part, it's massively different. I don't know if you can see the top of the screen here, but you can see the original numerator from which the final 923 and 956 came. So the proportion of the population invited and who actually take part is very, is hugely different, orders of magnitude. And that means the uptake of such interventions might be very, very low in populations. So you wouldn't have any impact on the whole population. And we have this evidence that we've changed dementia in whole populations without any of this, without any individualized approach at all. And it's probably a mixture of post-war socialized healthcare, education, social care systems, and basically we were just fitter. We became fitter as organisms and had better brains to compensate for pathologies that occur in the brain. And this is an analysis of EPIC Norfolk, which is another cohort, a huge cohort in Norfolk. And this is work by Seb Walsh. And this comes back to Jeffrey Rose's teaching, which is that if you have a high-risk approach, so if you take a population and you think, who in the population is at high risk, let's just target them, you will not address the issue in the population because most people who develop a disease come from the groups at lower risk, at middle risk, because there are far more people in that group, just simply by virtue of the distribution of risk profiles. So this is an analysis showing this for risk scores which are based on those multi-domain types of risks in the population. And in this middle-age cohort in Norfolk, we have dementia outcomes from routine records. And he was able to calculate the risk scores using various different types of risk that have been published from around the world. CADE is from Scandinavia, Libra is from the Netherlands, and Anu Adri is from Australia, and look at the distributions of the risk scores for the people who did go on to develop dementia and the people who didn't go on to develop dementia as captured in routine records. And what you can see here is these distributions are hugely overlapping, and the people who develop dementia, incident dementia cases of the red, are not so very different. They are at higher risk, significantly higher risk, than the people who are in the lower risk, who have the lower risk on these scores. So here they are higher here, as you can see, but most of the dementia is coming from here, from the middle risk. So we need population approaches to reduce risk in the entire populations in the way that we had between 1990 and 2010. So in conclusion, dementia and changing cognition with impact on daily life is very complex. True population representation is required to understand potential impact, and trials provide some proof of principle, but don't really give us solutions. Each are highly intensive, reach the more advantaged, but could be a benefit to those at the highest risk. High risk approaches will never address the bulk of late-life dementia. And for you, as the audience, apply critical reading skills to hyperbolic claims, whether about biomarkers or trials. Thank you. And I have to acknowledge many collaborators, our funders, but most particularly, of course, all the people who took part in our research, and their families, and the GPs, and all our interviewers and so on over the decades. Thank you.
That was absolutely fascinating. Thank you so much. I've already seen a couple of questions, and people have also sent me some individually. So we'll kick off in the interest of time. I'll just stop your screen share because it's still being shown here. Thank you so much. So one of the questions that came up is about the role of genes. And this is something that I think there's been a little bit more awareness of, or media coverage around this. So the person has said, obviously, we're not going to be answering individual questions here, but he said, I have 2 copies of the ApoE4 allele. I'm 62. I think I'd make a good case study looking at the role of a healthy diet, plant-based sort of whole food diet, and dementia. I'm doing potentially modifying lifestyle changes. Any suggestions would be welcome. What were your thoughts on, and this is obviously an individual case, but as someone who has potentially has this has copies of this this gene?
Well, it's very interesting. Just taking a step back, the whole issue about genetic testing and, and 23andMe and all of those kinds of opportunities that are advertised to direct consumer advertising, as it's called, do require a considerable amount of thinking and care. And of course, in a clinic, genetics counselling should be implemented before you even think about doing those kinds of genetic studies or finding that out about yourself, but about what the impact of knowing that also for yourself and for your family. And so this is a very important ethical kind of context for that kind of testing. And we've worked with insurers in the past saying that those kinds of measures should not be put into the algorithms that calculate your premium and so on. So these are quite tricky questions. So the good news, I think, in terms of apolipoprotein E4, because I think if you read the literature or if you read the media, you might think that you are destined to develop dementia in the same way that you might be if you had Huntington's Huntington's disease, where it's a dominant gene. But
Mm.
apolipoprotein E4 is not the same as that. And it is quite clear although you are at increased risk as an individual, that's from group data, as an individual, it is not deterministic. It doesn't mean that you will develop dementia.
Mm.
Whereas if you have the mutation in Huntington's chorea, you will develop dementia. That's wonderful news, the genetic modification and so on, changing clinical courses. But what varies with Huntington's disease is what time, how it manifests and the age. But apolipoprotein E4, it's the longitudinal studies suggest that only about half the people do develop dementia during their lifetimes. So in terms of the things that an individual might do once they do know, if they do go down that track, then looking at the risk factor, modifiable risk factors, clearly trying to make sure you've got optimize your vascular health, because we know that vascular pathology plays a major part in later life dementia, and apolipoprotein is E4. They are basically are vascular type genes, and good nutrition, absolutely. I might, for those who are pescatarians, I might say have some oily fish, but maybe have supplements, or make sure you have the
Yeah, we have an
flax
article
seeds and
on us.
the
What
plant-based alternatives. And so it's really looking at all those aspects of life and enjoy your day-to-day life, because I think that people can become so preoccupied with their future health, some decades into the future, that they forget to enjoy the things that they enjoy. And actually, social engagement and well-being are very important. So in our own study, self-reported health was as important as a predictor, if you like, or a risk factor as stroke. So optimizing your feeling good about how you are now is very important.
I love that advice. I think living in the moment, sometimes with genetic testing, it has to be delivered in a way that is ethical, that's appropriate, that sometimes private companies could be delivering some of this information in a way that could be really harming people. And I'm all for empowering people with information. I think we all are, but as you said, it's so important to enjoy the day to day. And coming to that, someone's asked the question, is depression, anxiety, or perhaps other mood disorders at a young age a significant risk factor for the development of dementia in later life?
Yes, it does increase risk. Yeah,
Mhm.
yeah. But again, this is talking about studies which are longitudinal, that's on groups.
Mm.
It doesn't mean that you will develop dementia if you have had an episode of depression in earlier life. So there's there's a lot of data on depression and mood and later life dementia. So it is the case, it is the case that early life does confer a somewhat higher risk. But there's also the phenomenon that when people are in the early stages of dementia, the likelihood of depression is raised as well. So it's not only a risk, but it's also part of the prodrome.
Mm. Okay, that's really helpful. I love the way that you talked about kind of inequalities and dementia risk, and so on, and and how these certain kind of groups are affected. And then I suppose it comes to for GPs seeing patients for small kind of short periods. How could they communicate that given what we know about kind of structural inequality and things? Are there still any kind of lifestyle related advice or interventions that can be delivered, given that these kind of there's real structural challenges in communities with high deprivation, and maybe access to health promoting educational resources is quite limited. It's always the socioeconomic determinants of health is something that's baked into lifestyle medicine, but it's difficult sometimes in practice.
Yeah, so it's very limited what you can do as an individual physician or practitioner. But there's good evidence base for smoking cessation and support, and there are just in terms of optimizing, say, diet. I think the thing to do is to try to look at your community and where there are those assets in the community that you might point people towards. So if you think that somebody maybe doesn't know how to cook,
Mm.
it's probably more appropriate to the younger age groups, but certainly to
No, I think any
a lot
age
of men
group.
don't know how to. Yeah,
Yeah,
but
one
yeah,
one of our partner groups is Made in Hackney, which do community cookery, and actually they have a huge number of elderly adults in their 70s and 80s who've never cooked before, and literally using a chopping board and a knife. You don't even need fancy cookery tools, but that even that act of cooking together as a community is so healing. So there's an exercise, whether it could be your church or it could be community exercise in the park, these sorts of interventions that are low cost but kind of multi-domain interventions. I think hopefully these are things that we need to keep investing in as a society and kind of encouraging, because they don't just have the benefit for the exercise, it's that those micro interactions and bonds that are formed and things. So I think that's so interesting. So another question, among education, social, cultural, geography, economic background, is there any one specific thing that's highlighted as the highest risk within equality and dementia? I don't know if that question.
so what is it? What is the
Yeah.
ingredient of inequalities that
Mm.
no that is so difficult, because you can pick out one thing. So that sort of snake, the life course snake of modifiable risk, has put a whole load
Mm.
of things in midlife, but actually the evidence base is really strong, and I've seen data today about hypertension in children. So these things, the tracking of blood pressure, for example, starts in early life. It
Mm.
probably even starts with the parents, and so it's multifactorial. And one of the things that Seb Walsh has done, in addition to the research that I showed today, is that he's looked at all the policies for which there are population level evidence base that you can change those risks in whole populations. And so there are a whole raft of things that can be done in communities. And so what would be really good, for practitioners, is not only to look at the patient in front, or the person in front of them, but also to think, how can I help to strengthen the things in the community that are there for everybody, so that we shift the risks. So the whole idea of the rose risk is to shift the risk of the whole population towards a lower risk state, so you have fewer people in the higher risk group.
Mm. Thank you. No, I think it's so sometimes we want to have that one answer, but as you said, it is all multifactorial. It's not easy to tease out some of these things. I've just launched a little poll for everyone. I have a feeling that I know what you're going to say to this, but I think it's so important to address misinformation. And someone has asked, what about therapeutic plasma exchange, saffron, or aromatherapy as interventions for dementia? And of course, we constantly see this as anyone who's on social media. There are sort of these sorts of alternative therapies or other things that are sometimes mentioned. What are your thoughts about this? And are there any out there that you think, oh, this could be promising? It's something you'd like to see more.
Well, I have to say that we have to do well-designed studies and dementia is very long, it's decades from
Mm.
risk to outcome. And if you measure it too close, you get the interference of things that are happening in the early course of the syndrome itself. So it's really important to understand intermediate markers or whatever, that vascular health, for example. So those alternative approaches need a trial base, and it's really important to try to generate as kind of robust an approach to experimentation as possible. And that's where the multi-domain interventions came from. It was just, there was all this observational evidence, and Mia Kivipelto thought, sure, I could just put this together. And she did, that she did the trials. And now, although I don't think that individualized intervention will kind of cut the mustard as far as populations go, what they have shown is this proof of principle that things can change, risk profiles can change a bit, maybe not very much, but a bit. And we have the evidence that whole population dementia has changed.
as you've so wonderfully talked about, I don't want to keep you, but I do have one more question that is quite interesting. What role does education play in whether someone develops dementia? Is it linked to early education or lifelong learning? And I suppose this is something that does come up, with all this sort of
Yeah.
brain puzzles and other things, different forms of learning. What are your thoughts well, not thoughts, what does the evidence say rather
Well,
around
we
this?
do go, probably does it. But we do have good evidence that people who have been exposed to longer education in early life, complex occupational kind of exposures, so challenging jobs, but not stressful jobs, but things which challenge you intellectually, and then social and intellectual engagement in later life. All of those things are associated with reduced likelihood of developing cognitive impairment in our studies, and increased likelihood of recovering from them if you have them across time, and faster death if you do decline.
Okay.
So that's what
Pushing the
pushing
envelope.
morbidity
Yeah.
towards the end of life. Yeah, that frailty. Because almost all of us go through some sort of frail, multiple morbidity stage in later life, and dementia is part of that process. Once you get to 85 plus, then it's you get a very high probability.
Thank you so much. So the end message is stay curious, keep learning, keep being challenged, and
Yeah,
thank you
and
so much.
enjoy life as
Enjoy
much as you
life.
can. Yeah.
Enjoy life, totally live in the moment. And we can so worry about, and it's so important to, not live in the life in terms of have all the tequila shots, but live in the
Yes.
life and live in the moment, enjoy it. I think it's
Within
such an
reason.
important message,
Yes. Yeah.
totally. And as we get more and more information about our genetic risk profile or the risk of certain conditions, it's easy sometimes to get. I've definitely had that experience. You can get quite bogged down in that. So I think it is such an important message. Thank you, and a really uplifting note to end on. Thank you so much for your time. It's been so illuminating, and it's definitely cleared up lots of things I didn't know about this and just how complex this field of research is. There's so much to consider. I really wasn't aware of that. I'm sure lots of the listeners weren't too. So thank you again, and we'll have to have you back in due course as and when more information comes out and more research is published. So thank you again for all that you do, and good night, everyone.
Thanks for inviting. Bye.